Easy case to start with, yeah, boss.
Okay, so this is X-ray pelvis and proximal femora of the skeletally mature patient. Here I can see that there is lateral displacement of the right femur and right femoral epiphysis, which is not falling between in the lower inner quadrant of the right hip joint. So in summary, the findings are of right developmental dysplasia of the right hip joint. If I want to further explain it, that there is disruption of the
Yes, it's better
frontal
to
lines
describe.
and
Yes.
heel. I cannot pronounce the heels. Uh, the other line which is transfers going through the both acetabuli, upper margins of both acetabuli.
Okay.
Yeah,
This is the horizontal line, Helgenreiner, and the vertical, maybe here, the vertical line, I think Birken line. Okay.
yeah,
So
Birkin line. Yeah,
it's a little bit superior and outer
yeah,
as a location. And as a size, it's smaller than the opposite
then
one and of reduced density. Is regarding the epiphysis. And regarding the acetabulum, it's shallower as
yeah.
compared to this one. Okay,
Mhm.
very good. And Shenton line is disrupted, unlike the opposite one. So DDH on the right side. Why or when we do ultrasound?
Before the age of ossification, like first few months, we will do ultrasound, and after ossification, we will do X-ray.
Okay,
So
okay. But يعني till the age of nearly 4 months, 4 to
yeah,
6 months. Very good. But starting from first week or second week or when? Hip
the
ultrasound. Hmm. Hip ultrasound. When we do it. You told
uh,
me the maximum limit, but the minimum,
I can't remember
no
exactly.
problem. After 4, 6, 2 weeks, okay, everything.
Four weeks maybe.
They wrote everything. Okay. The standard 6 weeks, 6 months.
Okay,
Okay.
thank
Six
you.
weeks,
Yeah.
6 months.
So
Okay. Why not before 6 weeks? This is a possible question because of
this is
maternal hormones.
yeah.
Maternal hormones transmitted to the baby, causing laxity of the joint. So
Mm.
I cannot judge the true displacement or no. Okay, so 4 to 6 weeks, 4 to 6 months, accepted, of course. Now another case, 2 months child. This is
So
okay, this is a
okay,
normal
so
side, and this is a abnormal. Starting with the
normal
normal
side.
side. Okay. Hmm.
Okay, so I have been presented with selected images of the hip joint, ultrasound images of the hip joint. So here I can see that there is a line which is passing through the acetab, the this is right iliac bone, and passing the other line is passing through the acetabular roof.
Okay.
So it is producing alpha and beta angle. It is showing angle almost more than 77 alpha angles, which is normal limit.
The normal limit
I,
is
66 or 77%
60,
exactly. I
60,
didn't.
60. Okay,
Yeah.
60.
Okay.
So this is
Yeah.
very good. This is very good. Okay. Yes, very good. So this is normal. I
Yeah.
will revise after you finish. And now this is the left side.
Yeah. So on left side, I can see that there is widening of the beta angle and widening of the shortening of the beta angle and widening of the alpha angle. So it represents there is uncovering or
You are not
um,
generous in your description, yeah, boss.
because I'm not doing pediatric ultrasound. So
No problem. But it's a very important part in the exam. Take care.
yeah,
Pediatric
yeah,
ultrasound. Take care. Okay, no problem. I will revise this case with you. Here the normal, my friends. This is the ilium. This bone is the horizontal bone is the ilium, and this is the bony acetabulum, and this is the acetabulum labrum. This echogenic part. This is the pubes. So the femoral head, by description, this is subjective, and the angle is objective. Subjectively, the femoral head is rounded, preserved shape, present normally in its socket. And if we do a femoral coverage ratio, more than 50% of the femur, more than 50% present in its socket. This is regarding the femoral epiphysis. Regarding the acetabulum, it's steep, normal. And regarding the labrum, it's triangular in shape, normal again. This is as a description. And now to the angle, it's a normal alpha angle, more than 60%. Very good. But now, okay, I will remove this notation, okay, to write new. This is the ilium. What about the bony acetabulum? Should be here. Shallow acetabulum, very shallow. What about the triangular shaped labrum? It's deformed, everted. Okay. What about the humeral head? It's out from its socket. If we do a femoral coverage ratio, it's most or more than 50 or 70%, for example, outside its socket. Okay. This is regarding the description. And again, the alpha angle is very small angle. It's very reduced. Okay. This is a high stage DDH. I need to do a complementary dynamic ultrasound as well, because this is static. What about the treatment?
Treatment is surgical.
Oh, surgical treatment. Okay. Okay. No conservative treatment. We do a fixation of both
Okay.
hips. It's called a Pavlik harness. It's important to know a very little information about the treatment. It's called Pavlik harness. 23 hours placed per day, and 1 hour we can remove it. Okay, very good, very good. Okay, this is the first group. Now the second group, 70 years
Okay.
old male.
So this is anterior and posterior projection of whole body scan of the skeleton. So here I can see that there is increase in activity in the appendicular skeleton, particularly the cortical tram-like uptake in both
Good.
femora and tibia.
Very good.
And there is slight heterogeneous tracer uptake is also noted within the spine and multiple ribs and humeri and long bones of the forearm. So in summary, the findings are most likely of metabolic bone disease. So I will check the clinical history of the patient, how the patient is presented, and
Are you sure, yeah, boss, it's metabolic bone disease?
it can be metastatic, but I will check the clinical history of the patient. If the patient had known,
Metastatic? Okay, no problem. Revise after me, no problem. Yes, it's a hypertrophic. We have two steps in describing bone scan. First, after presenting, this is a whole body bone scan in anterior and posterior projection. The first item to describe is the presence of renal uptake, yes or no? It's present here, yes. So there is good renal uptake by both kidneys, excluding super scan. It is not super scan, not metastatic super scan, not metabolic super scan. Okay. What else? As you mentioned, linear or tram track uptake along the appendicular skeleton. This is very good description in a non-homogeneous or non-uniform pattern affecting lower extremity as well as upper extremity. Enough. Everything else is normal. So the diagnosis will be hypertrophic osteoarthropathy. The next term or the next sentence in my routine practice, I will correlate with the patient history. I will correlate with other radiographs. My differential diagnosis, I'm waiting.
So, differential diagnosis in this case, this could be due to pulmonary fibroma, bronchiectatic changes, or this may be associated with pulmonary um, like lung cancer,
Mm,
or
we need
this.
revision because this is a very important and common exam case. Okay, as you said, the secondary causes more than 95% of the causes, like pulmonary and extrapulmonary. Pulmonary, like bronchogenic carcinoma on top of the list, or chronic non-neoplastic pulmonary conditions, cystic fibrosis, COPD, chronic lung abscess, bronchiectasis. Pleural also, like mesothelioma and the pleural fibroma. Extrapulmonary, like alimentary and congenital heart disease. Alimentary, like cirrhosis, sclerosing cholangitis, and ulcerative colitis, celiac disease, and so on. You have to remember these causes very, very, very good. It's a common exam case.
Okay.
Okay, boss. Now to another very easy, inshallah. Not very easy. Okay. Pain.
Okay, these are uh, frontal projection of the both feet. So here I can see that there are subluxation at the bilateral subluxation involving the metatarsophalangeal joints of the both feet.
Good.
There is also flexion deformities which are present along the interphalangeal joint of the second, almost all of the phalanges of the both toes. Looking at the bone density appears within normal limits. There
Good.
is no joint. There are no joint erosions, and the rest of the tarsal bones cannot visualize
Yes.
in this image. I can see internal fixators involving
Good.
the
Good.
distal.
So we
Uh,
have significant luxation or deformities. Okay.
yeah,
And fusion. You see here erosions and
yeah, inside
fusion.
also.
Okay.
Yeah.
Consider this is a hand.
Mm-hmm.
Deformities and diffusion. Fingers and or metacarpopharyngeal, not
Mm-hmm.
metatarsopharyngeal. Consider a hand.
Mm-hmm.
Metacarpopharyngeal, ulnar deviation, and the carpal fusion. What is the diagnosis?
The symmetrical involving both
Yes.
metatarsophalangeal joints, so rheumatoid arthritis was differential
Excellent.
diagnosis.
Yes, yes. I know it's atypical to be seen in the foot, but this is exam-wise. Okay. This is
Yeah.
the same patient, okay, a carpal fusion and the proximal erosive arthropathy with some deformities. And this is the feet of this patient. It's rheumatoid arthritis. I refer this case to a rheumatology and compare with other imaging. So this case is rheumatoid arthritis. What about this patient with hand pain?
Okay, these are frontal projection of both hands. So here I can see that there are subchondral erosions which are present at the fifth metacarpal of the right hand. There is the articular erosion which is present on the lateral aspect of the same
Very good.
metacarpal. There are also joint space appears preserved on the phalangeal and metacarpophalangeal joints. There are also erosion which is present within the carpal bones with the disruption of the
So it's a
intercarpal.
classic this time. Okay. Easy this time.
So intercarpal joint spaces and radiocarpal joint. So these are the finding are suggestive of rheumatoid
It's a
arthritis.
classic. This time is
Yeah.
classic. Juxta-articular erosions and also here carbo and intercarpal and radio carpal. Okay, this is very easy this time. By the way, same patient. Okay, same patient. Juxta-articular erosion and subluxation. Remember, rheumatoid arthritis
Rheumatoid
can affect
arthritis.
the feet, especially in the exam. Okay.
Okay.
Okay. I'll give you another key. Yes, this one. Pain.
Okay. So this is again frontal projections of both hands. So here I can see there are juxta-articular erosions which is present involving the um, second metacarpal of the left hand and proximal base of the proximal phalanx of the
Okay.
same finger. The joint space appear preserved. There is also
Concentrate on
erosion which
this.
is present.
Yes, on this area because this is very specific.
Okay, so there is also joint space appear preserved. However, there is soft tissue swelling which is associated
Yes, very good.
along the medial and lateral aspect.
What
The
about the description of this type of
this
erosion?
this looks like red overhanging edges
Excellent.
of the
It's
so
very well
overhanging edges
defined.
of
Very good,
yeah
very good. It's very well defined erosion, and it has a hanging edges, like punch it out. Very good with some soft tissues. So with this criteria, the diagnosis will be
gouty arthritis.
gouty arthritis. Yes, I know you يعني you expected to see gouty arthritis in the feet.
Yeah.
Okay, but in the exam you will see it in the hand. Okay,
Okay.
take care. Okay, very good, Yabus. Very good, very good.
Thank you so much.
Thank you. And this is in a case of the feet. Thank you, Yabus. Thank you.
Thank you so much,
Okay,
sir.
welcome, welcome. The next candidate.
Yes, sir. Assalamu alaikum.
Alaikum salam. How are you, Yabus?
Yes, sir. Alhamdulillah, I'm good.
Okay, easy case to start with.
Uh, yes, sir. This is X-ray pelvis frontal projection of a skeletal immature patient. I can see there is sclerosis and loss of the left-sided femoral head with the flattening of the femoral epiphysis. Finding are likely in favor of Legg-Calvé-Perthes disease. However, I would like to know the history of this patient, and I would like to review any other orthogonal views if available. And
Good.
would
What
recommend.
if the patient has this is another patient, and when you compare the previous radiograph 1 year ago, it has the same appearance. Any differential diagnosis rather than Persis disease?
So this is the same patient?
Consider the same patient and similar finding along 1 or 2 years.
Okay, sir. Any other diagnosis? Sir, it could be eosinophilic granuloma or any other other than
Yes.
avian.
Dysplasia, epiphyseal
Okay.
dysplasia. Do you know any
Okay.
epiphyseal dysplasia?
Yes, sir.
Dr. Zainab already wrote. Okay, it's called Meyer dysplasia.
Okay.
Okay,
Okay. Okay.
it may affect if bilateral symmetrical, it's okay, but if unilateral, I need to compare with previous radiograph to see
Okay.
any changes. Very good. This is Persis disease. I'm asking you now about causes if Persis is idiopathic.
Yes, sir. It is most commonly
What are
idiopathic.
what are the causes of AVN?
Sir, it could be traumatic or, sir, excessive steroid use. Sir, even infection can cause that. Um, or, sir, any other metabolic disease that can lead
Good,
to avian.
good. In children, especially, please don't forget to look at the vertebrae. Why?
Uh,
Very
sir,
important. In
Okay.
children, if you see a bilateral, look at the vertebrae.
Okay.
Why? Okay,
Sir,
why?
sir, to rule out sickle cell.
Yes, yes. Depression, central depression or H-shaped vertebrae in your exam. Okay,
Yes,
if you see this, go to this area. If you see
okay.
H-shaped, okay, it's a sickle disease. Sometimes urinary bladder or rectum displaced to the left side, so it will be a renal transplant. Or surgical clips, it will be a renal transplant. Or sometimes you will see a convoluted tube like this one. It's peritoneal dialysis catheter again. Okay, so
Okay.
or Bismillah, a lead pipe, featureless colon. Okay,
Okay.
like an ulcerative colitis.
Polite.
See the associations. Okay,
Okay.
alcohol use, of course, but in adults. Okay, okay. Uh, yes, I think yani, this is beyond the exam. This is the epiphysis and the metaphysis. If the epiphysis is irregular, this is diagnostic of Perthes disease in ultrasound, but I don't think it's within the scope of the exam. Okay, I'll give you ultrasound case just to revise the normal. To revise the normal. This is hip ultrasound. This is the physis. This is the epiphysis, metaphysis. This is the acetabulum. So this is the hip joint. Normally, we should not see any fluid in this area along the metaphysis or along the neck. It's called anterior recess of hip joint. Very, very, very important in practice. Very important. This is called anterior recess of hip joint. Should be empty. Okay. But in this patient, the symptomatic side has some fluid. The normal side, no fluid. If this fluid thickness with a synovium more than 3 millimeter, we consider it significant. Ignore this patient. Ignore this patient. 5 years old, normal lab, no fever. It's a case of transient synovitis. It's
Okay.
What about this patient? Let's see 8 years with hip pain. This is the right and this is the
Okay.
left, complaining from the left.
Okay, sir. This is one of the ultrasound image of the hip joint. I can see there is widening of the anterior recess of the hip joint, indicating effusion, joint effusion on the left side.
Clear or turbid?
Sir, it's turbid. It's not clear. It has
Good.
subtle ground glass echogenic echoes, likely infective, indicating sir, infective etiology, likely septic arthritis. And this patient
Okay,
needs immediate.
you describe it. Okay. Now, just a summary or diagnosis. You diagnosed septic arthritis based on turbidity, correct?
Yeah. Yes.
So no need to correlate with the patient history.
Sir, patient has history of fever and pain.
Use the magic F. If the patient has history of fever and marked limitation of movement and severe pain with inflammatory markers high, I would suspect the possibility of septic arthritis. If the patient has no fever and normal laboratory test, let's see here, left hip pain,
Okay,
no
without
fever, normal PSR or C-reactive protein, which means it's not inflammatory.
non-infected. Yes.
Yes. So the diagnosis will be
Sir, could be sir rheumatoid arthritis, sir.
no.
Sir,
By the way, my friends, all of you concentrate on this point. Turbidity in the anterior recess is not diagnostic of minimal diagnostic value. Turbidity may be seen with transient synovitis. Clear may be seen with septic arthritis. It's okay. So use the magic if the patient is complaining of fever, marked limitation with increased inflammatory markers, diagnosis of septic arthritis. In such a condition, what is the management?
So that patient needs aspiration cytology and culture
Urgent.
and
Very good. Very good. And plus or minus MRI. If the
yes.
patient has no fever, it's transient synovitis, no
Okay.
rheumatoid. Transient synovitis. This is the two common differential diagnosis. It's very important. Okay, transient synovitis, conservative treatment. Okay.
Okay, sir.
Okay, let's go to يلا this case إن شاء الله easy.
So this is one of the image of the bone scan, and I can see almost bilateral and symmetrical uptake in the femur and tibia bilaterally. Sir, I cannot appreciate the kidneys in this image.
Yes,
So,
I'm waiting for this. This is step one. Okay, kidney uptake is not seen on both sides, denoting super scan.
super scan, yes, sir.
Followed by the uptake is seen mainly in the appendicular skeleton in a
Yes, sir.
homogeneous, uniform pattern on both sides, suggestive of
Super scan.
uh,
Sir,
absence,
so metabolic.
step by step, absence of renal uptake equals to super scan. Appendicular skeleton uptake equals to metabolic super scan. So two-step approach. Okay يا boss?
Okay, sir.
Absent renal uptake equals to super scan. Appendicular skeleton uptake over the axial equals to metabolic super scan. I want to correlate with the patient history and mention the differential. Differential of metabolic super scan are
Hyperparathyroidism, sir, renal osteodystrophy, and sir, others include
in old age, for example, very
in old
old
age, sir,
patient,
sir, multiple myeloma,
multiple
leukemia.
myeloma on bone scan.
Sorry, sir. Multiple myeloma is not
Oh,
detected on this.
I will not
Sorry.
give you another case.
Okay. So mets or metastasis or
No, metastasis, metastatic super scan, not metabolic. Huh? What is this
okay, sir.
sign? It has a certain name, like American president.
Sir, so Paget's
Abraham Lincoln.
Lincoln, sir. Abraham
Okay,
Lincoln.
it may be Paget disease, and in young age or in children, also osteopetrosis. You need some revision of the ultrasound and nuclear. Okay, back again to types of arthritis. Let's see this case first. Okay, Bean.
So this is X-ray frontal projection of a skeletally mature patient. I can see there are marginal erosion and loss of joint space in the proximal interphalangeal joints of
And
both hands, more on the right side. Uh,
proximal only?
so proximal as well as distal, with overhanging edges. Yes, sir. With
Yes, very good. Okay, with marginal
erosions.
bone forming, with marginal bone forming. So proximal and distal, you see this sign, it's called
So Guelving sign, and it is seen in cases of psoriasis.
I'm sorry, what is the name of the sign
Sorry,
again?
sorry, sir. This is Guelving sign or over seagull sign or Guelving sign.
No, not seagull. Mouse, ears.
Okay.
Mouth, ears. It's a new bone formation at the edges. Distal, by the way, this is a case of distal erosive arthropathy. What are the causes of distal erosive arthropathy?
Sir, psoriasis. So
Very
erosive.
good. Yes, good. Psoriasis, like this case, just pertinent negative, no acroosteolysis, no soft tissue calcification. This is a psoriasis, distal erosive arthropathy, interphalangeal, proximal, and distal. Okay, with new bone formation. It's not pure erosions. You see here, not pure erosions. Some bone formation at the edges. Some bone formation at the edges. Mouth, ears. What about this case?
Sir, this is X-ray frontal projection of the hand. I can see there is loss of joint space with the erosions, erosions, marginal erosion, as well as new bone formation and periosteal reaction along the proximal interphalangeal joints of both hands with with associated soft tissue swelling. There is
Sign.
sir, again, this is the seagull sign.
Yes, correct this time. Okay, this is seagull. This is a classic seagull. Okay, يلا the last case. This is seagull, erosive osteoarthritis. I want to correlate with the patient history. What type of history?
Sir, sir, any history of sir, like these are painful, and patient also has raised inflammatory markers.
Good. And type of patient?
Sir, it is like old patient,
Male or female?
mostly female.
Okay, postmenopausal female. Very good. I'll give you another case. Just a minute. Yes, this one is the last case.
Okay, sir, this is X-ray hand frontal projection. I can see there are marginal erosions and loss of joint space involving the distal interphalangeal joints with the asymmetric joint space narrowing and such soft tissue swelling. I can also see calcification along the proximal phalanx of the middle finger. So few calcification, linear punctate calcification are seen in the adjacent to the distal radius and within the soft tissue.
So this is calcification.
Yes, sir, it seems to be projected over the.
This
So
is
this could be.
calcification.
So, so this could be surgical clips or
Yes, yes.
projected over the.
Surgical clips. What about this fine line?
So this is arterial calcification.
Yes, vascular calcification. But the patient is 25 years old.
Okay.
Step by step. What about this? This
so
type
this,
of arthritis is?
Sir, involving the distal interphalangeal joints, sir, with calcifications, I will go for metabolic diseases.
Step by step, step by step. This is the seagull again. You see it?
Yes, sir.
Correct?
Yes, sir,
Seagull.
seagull.
Okay. Maybe some erosive osteoarthritis. Okay. The patient
sir.
may be 40, for example, يعني not 25. But soft tissue calcification with
Yes, sir.
early vascular calcification
Yes,
and
sir.
surgical clips at exactly at this location.
So fistula formation, maybe.
Yes. Hemodialysis, fistula,
Hemodialysis fistula. Yes,
surgical
sir.
clips, likely
Yes,
secondary
secondary.
hyperparathyroidism, vascular calcification, soft tissue calcification. I need
Yes.
additional views to detect what?
Sir, to detect the to see the other signs in the like subperiosteal desorption and.
Very good. And terminal tuft resorption, for example. Very good, very good. And ask for
Sir, skeletal survey to see other manifestations.
okay, and the laboratory test as well.
Yes, sir.
To
Serum
check the renal function
thyroid
and calcium
yes.
level and maybe
Yes.
parathyroid ultrasound. Very good, yes. So this case has two pathologies, not related. Distractive one is the erosive arthritis, erosive osteoarthritis with seagull, and one of the hidden pathologies, hyperparathyroidism, secondary with dialysis fistula formation. Thank you, Abbas. Thank you. I know
Thank you, sir.
arthritis in the hand may be a little bit difficult with some hand يعني, hidden findings. No problem. No related, not related. These two conditions, not related. Okay.
Thank
The
you so much,
next.
sir.
Welcome, يا boss. Welcome. Best of luck, inshallah. The next candidate.
Assalamu alaikum.
عليكم السلام ورحمة الله وبركاته. Just to remember the last case, turbidity doesn't equal septic arthritis. This case diagnosed as transient synovitis. What about this patient with limping?
Candidate 3, are you with us?
Yes, yes. These are grayscale ultrasound of right and left hip joints. There is joint fluid noted in anterior hip joint recess, which appears clear without any internal debrinous contents.
Good description.
There is mild and mild widening of the left anterior joint recess noted as well, with which appears slight turbid. I will correlate my
This one maybe just is the capsule. And this is a capsule. Okay. So this one is asymptomatic. This one is asymptomatic. So clear joint effusion. How to deal with this case?
I will check the clinical history of the patient and also the clinical notes and ask the history if the patient is acutely unwell and febrile. So it can represent septic arthritis, and we'll also check the age of the patient. And next, I will proceed with the joint fluid aspiration and send for culture and sensitivity.
Excellent, excellent. This patient, although clear, but intense pain, okay, some fever, elevated C-reactive protein, elevated inflammatory markers, and white blood count. So, my friends, echogenicity, turbidity is not of great importance. Okay, I need to correlate with the clinical, I need to correlate with the inflammatory markers. Let's see this case. Limbing.
Please do not unmute. Sir, she's muting herself
Okay.
again and again. I have to ask her again and again.
Do not unmute yourself, ya boss. Do not mute yourself, okay?
Yes.
This is the coronal image from T2-weighted MR, bilateral hip joints, in which I can appreciate there is mild amount of joint fluid noted in right hip joint, and the articular margins appear intact. However, there is slight hyper intensity noted in acetabulum.
You can ignore the acetabulum. Acetabulum is normal. So the only finding here is joint effusion. What is the diagnosis?
So it can represent septic arthritis.
Okay, I will answer after the second case. I will answer after the second case. This one, yes, here. What do you think this one? Another child with limping. I will answer both cases, my friends, but just after my friend answer. Okay. Okay, proceed, ya boss.
So in this case, altered signals are retrieved from right femoral head as well as acetabulum, along with decreased height of right femoral head. So it can represent avascular necrosis. I will take the history of the patient and check the clinical notes. If
Child,
this is
child with limping, 8 years, for example, or 7 years with limping.
Child with lingual. So if it is acute presentation, it can represent septic arthritis.
Yes.
As well.
Why septic arthritis, not avascular necrosis? You change the diagnosis. Why?
Yes, the presentation is acute and also the margins appear intact. Margins are regular. Right femoral head margin, and also there is
not this clue. Not this clue.
T2 weighted hyperintense signals are noted on both sides of joint.
Yes, very good, very good, very good. Okay, so concentrate, my friends. This is a case of transient synovitis, and this is a case of septic arthritis. In transient synovitis, the joint is normal, both sides of the joint. The femoral head is normal. This is a stare, okay? It's a suppressed image. no edema, and acetabulum normal, and no narrowing, no irregularity in the cortex on both sides. Just simple joint effusion. It's a transient synovitis. Okay, no edema. But this one, oh, edema pattern in the head. It is not necrotic. No areas of low signal intensity. No serpiginous structures here. No subchondral low signal intensity. It's not EVN, not Perses disease. But edema on the femoral head and the edema pattern also on the acetabular side. Where is the cortex? Oh, there is cortex erosion. Where is the remaining joint space? It's already obliterated. Okay, so we have some effusion and we have articular changes on both sides and some edema in the muscles. This is a septic arthritis. It's very important to differentiate these two entities from each other. Okay, boss, what about bone scan first? What about this patient? Let's see. Okay, old male.
These are anterior and posterior planar images of bone scan. Intense radiotracer uptake is noted in axillary skeleton as well as right iliac bones, and also in
You
bilateral.
commented on the kidneys.
Yes, I will comment now.
Okay,
No radiotracer uptake is noted in bilateral kidneys, so it
good.
is super scan.
Very good. Step one.
So super scan, and the intense radiotracer uptake is noted in axial skeleton.
Very good. Step
So
two.
it is most likely in keeping with the metastatic super scan.
Good.
As this is a female patient, I will check the clinical nose history of the patient if the patient is known case of any primary malignancy. So these are metastatic deposits. Otherwise, I will do the breast ultrasound of the patient, and will advise the workup to look for any primary disease.
Okay, so if a female, okay, agreed. Breast cancer on top of the list, I need to do a bilateral sonomammogram and correlate with the patient history and histopathology. This male, how to deal?
If male, then I will do the ultrasound for prostate and PSA levels.
Good. If PSA level is elevated.
If PSA level is elevated, then we will go for transrectal biopsy.
Okay,
And
by ultrasound and MRI prostate as well. Very good, very good, yeah, boss. Okay, other differential diagnosis, cancer. We said cancer, prostate and breast carcinoma. Two other differential diagnoses.
Cancers can be lung cancer.
No, lung cancer sending sclerotic metastasis. No, later.
Okay, so these can be breast. These can be stomach cancer, and also these can be bladder.
No, revise, yeah, bosses, revise. Okay, transitional cell carcinoma, usually, or urothelial cell carcinoma of the urinary tract and the lymphoma. So we have four main differential for metastatic super scan. In a female, cancer breast. In a male, cancer prostate. In either gender, transitional cell carcinoma of the urinary tract, especially the bladder, and lymphoma. These are the four main pathologies. Okay, hand pain.
This is the dorsopalmar view of the hand of an adult patient. There is joint space snaring of metatarsal joint noted with subchondral sclerosis. Noted, and there is also subluxations involving second to mainly involving third to fifth metatarsophalangeal joints, with lateral deviation of distal fingers.
Ulnar deviation. It's ulnar deviation. Okay, mainly.
Yes,
And
deviation.
no erosions. No erosions.
So I will check the age of the patient and history of the patient. This is most likely SLE.
Yes, very
And
good.
also advise the ball catcher's view for further confirmation.
Yes, yes. Systemic lupus erythematosus. This is, by the way, my friends, is the normal osteoarthritis.
Yes.
And by the way, this is common among radiologists who do ultrasound like me. Okay, very common. Okay,
Right.
incidental find. Very good, yeah, boss. Another
Um,
case. This patient, 12 years with pain.
This is the dorsopalmar view of wrist joint, in which I can appreciate there is a ill-defined lytic area noted in distal radius, distal radial metaphysis ulnar side. So it can be it is also associated with periosteal cortical
Good,
disruption. However,
good.
no obvious soft tissue abnormalities seen, no lytic or no chondroid or sclerotic osteoid matrix seen. In this age, it can represent a metastatic deposit from neuroblastoma, or it can be as the
Metastatic on
generalized.
the first one.
No, it can. There is also generalized reduced bone density. It can be metabolic disease like leukemia or lymphoma in this age of
What
patient.
is the commonest location as a start point for osteomyelitis? Epiphysis, metaphysis, diaphysis.
Metaphysis. So I will
Okay,
check the history of the patient. If the patient is acutely unwell, so it is most likely osteomyelitis
very good.
involving diaphysis of
Very good. Especially if inflammatory markers are high. Other differential diagnosis of aggressive bone lesion, maybe eosinophilic granuloma, maybe metastasis from 1 to 3. Okay, very good. But put osteomyelitis first, please. And also, this is يعني, rather solid preosteal reaction. Urgent referral and urgent MRI. It was osteomyelitis. Okay. Another case, yeah, boss. What do you see?
This is the dorsopalmar view of the hand. There are multiple um, terminal tuft resorptions are noted, as well as bilateral subperiosteal resorption or involving the radial aspects of proximal phalanges. Also,
Good.
there is generalized reduced bone density. Calcifications are noted on the radial aspect of the distal arm soft tissue,
This is
or also
calcification.
calcification metallic lips.
Metallic density.
Yes,
Metallic density.
metallic lips.
Okay. Okay.
Yes.
But يعني the same pathology. يعني swelling with calcification, swelling with metallic densities. Together with these findings, the diagnosis will be
Secondary hyperparathyroidism.
yes. What type of acrosteolysis is here?
This is band-like
Very good.
across.
Very good. Mid shaft or band like acrosteolysis. It's unlike terminal tuft. يعني maybe here terminal tuft and here mid shaft or band acrosteolysis. It's suggestive of hyperparathyroidism. The last questions. Causes of acrosteolysis.
Causes of acrosteolysis scleroderma, hyperparathyroidism, SLE, other these connective tissue disorders, also involving rheumatoid arthritis,
Good.
frostbite.
Good. How to rule out frostbite as a possible cause?
Frostbite mainly involves the, I think, distal middle phalanges mostly.
No. In frostbite, weather is so cold. So the patient gathering all fingers and the thumb will be in the middle, covered by the fist. So the thumb will be spared.
Okay,
Thumb
okay.
will be spared. It is not spared here. Okay, so other differential are present like hyperparathyroidism, scleroderma, and. Thank you, Abbas. Thank you.
Okay.
Well done.